like really to give the word to Anton, whose company has developed a vascular-specific inflammatory enzyme, which is implicated in predictive of rupture-prone plaque. And you know how CBD is leading this condition.
Thank you, Jody. Yes, as I think most of the people know, cardiovascular disease is the #1 disease worldwide and assumes also a lot of cost in the healthcare systems in the different countries. And prediction and prevention could make a major change there. Of course, we have to do evidence-based medicine, and over the last 25 years, there's a lot of research done. And we have made, I think, in general, big progress. Recent numbers from the CDC in the US have mentioned that there is a reduction from about 30% over the last couple of decades, mainly because of some drugs that came on the market, the statin drugs, that's being discussed with people who are working in this field very often. And the other thing what has made an effect is, of course, preventive measures. And one of them is smoking. And as you all maybe remember, not so long ago, maybe we were smoking in a room like this, or at least at home or at the office. And over the last 5 to 10 years, now in nearly all countries in Europe and in the United States, smoking is prohibited in the workplace, in meeting rooms. And I think that has definitely also had a big impact on reducing the number of cardiovascular disease. And another important point was developing risk prediction systems. You know, Framingham risk score, the European score system have also helped, especially primary care physicians, to give them some guidance what are the important risk factors for cardiovascular disease. But I think we have come now on a crossroads. With all these new developments, we come to the conclusion we missing still about 50% of the people who have cardiovascular death. And with a lot of research which is done, we have not made much progress yet. Also, new drug developments are very, very slowly. There is not a lot of new drugs on the horizon who can help us maybe on top of the statin drugs we have. But if you look to the cost factor of it, and we talked about this today a lot, and say, you know, what can we do to treat the people who are sick? I think we have maybe to make a shift and say, can we spend some of the money, what will be available in the healthcare system? Because we all agree we cannot go on with the increasing cost of healthcare. But if we take some of the cost in the healthcare system and move that to really focus on prevention. I know we talked for the last 25 years on prevention, but that does not mean that there was a real commitment in prevention. Coming back to a little bit to the product what my company makes, we are now, since 1998, so we have 14 years of research, because the bars are so high now to put a new biomarker on the market because of evidence-based medicine, but even more higher because you are in the field of prediction. You predict and prevent that maybe some people in the future will have the disease. And that's where, of course, a lot of people in the health care system say, where are your proof? And here we can talk for a long time which studies need to be done and who's going to finance that. That when these studies are so convincing that when you do these tests, that people will get this disease or not in the next 10, 15, 20 years. But on the other hand, what I have heard from the doctors now who are using some of these new tools, because they said, we don't want only treat the symptoms, like people have high cholesterol or high blood pressure, I'm going to treat them. I want to know what the root cause can show that these people did not get a heart attack or stroke. Of course, then the science people will step up immediately and say, that is not a study, but and not an evidence-based, double-blind, placebo-controlled study. But you need somewhere to start to collect the data to show that new forms of risk prediction and treating with maybe lifestyle changes or drugs that have been approved will have an effect to lower the disease and then also long-term lower the cost in cardiovascular disease and stroke.
I think the minister had it right when he said that really only the patients and their families or their dependents can make the decision about what is an acceptable risk. In the previous session we heard about how expensive it is to run clinical trials according to the current paradigm, and that's what drives the cost of the drugs up apparently. But yet what comes out of those clinical trials is a binary answer. Yes, no, at a 95% confidence level, which is not really enough information for the patients. They need to know the side effects, for example. They need to know more information. There needs to be more information out there, perhaps new paradigms. The biomarker, for example, if the patients knew what in some patient understandable way, what the risk was that they would get a false result from it, it could be quite useful in the overall mix. I think that we need to move from a binary yes-no type of regime to an internet. Well, here's all the information, and this is the best information, and you, the patient, has to make the decision. If we can move to that paradigm, actually, it seemed to me as though there was significant cost benefits as well as potential therapeutic benefits.